All right. Hey, guys. It's Miss Furr and Miss Springer. We wanted to talk to you for a few minutes about a couple of things that you need for Sims Lab coming up on Wednesday regarding the communication chapter.
So in preparation for lab on Wednesday, it is a lab day, so you will wear your uniform. And then we want you to bring all your supplies that you would bring every lab, which would be things like your stethoscope, your blood pressure cuff.
Pen light.
Yeah.
Anything that you would use to perform an assessment or vital signs, any little thing that you may want to use in clinical to take notes on, something like that. We're going to have some pre-made forms for you, but if you need something additional, yeah, you're welcome to bring that. You do not need any kind of checkoff or anything for this simulation lab. This is simulation, not necessarily a skill checkoff. So there'll be a little bit of pre-work, which you're going to do right now by watching this video and kind of studying and reading through the chapters. And then you're going to have some work that you're going to have to do on campus in addition to the actual simulation, but some write-up and answers and responses to questions and scenarios. Please, please, please make sure that you bring your student workbook for the fundamentals book on Wednesday as well. You'll have to have that. It is the blue in color one, just like the fundamentals book. It's about a third of the size though, and it says workbook on the front of it. So you'll need to bring that. You will have pages that you'll have to do out of that workbook that will be assigned on Wednesday.
And you'll complete your entrance exam for your ATI. You won't have to worry about that. We'll just go to the computer lab. We'll tell you all that information on Wednesday.
So bring all those things, and we're going to have a little video lecture here on Chapter 6 so that you don't have any additional lecture on Wednesday. When you get here, you just get to actually step right in and start doing hands-on. That being said, it is very, very important that you listen to this video, listen to this lecture, and read before you get here. If you haven't done that, you will not be successful in Simulation Lab on Wednesday. So please make sure that you utilize this between now and the time you get here on Wednesday morning. That being said, you need to be here at 9 o'clock, 9:30. 9:30. Be here at 9:30 on Wednesday. We're going to break off into simulations after that. And the reason you get to come in at 9:30 and still get credit for all of your hours is because you're watching this lovely video and doing some of this pre-work at home to make up for that little bit of class time that you're missing. So be here at 9:30. All right. So starting off, Chapter 6 is on communication and relationships. This is communication between you and patients, you and physicians, you and other nurses, your employer, family members, everybody. This is going to cover how you talk to people across the spectrum. So first off, you have a sender and a receiver. Anytime you're exchanging information through the process of communication, you have one person who is supposedly giving out that information that they want. The other person is listening, processing, accepting that information or not, and then providing feedback as to how they feel the information is received, if they understood it correctly. And that feedback is really important because this gives you the opportunity to determine, did they understand what I meant, or did I need to do something different? And if you did, then you can clarify. And so this is a cyclical pattern, obviously not a one-time thing. Every time that you exchange information, you are going through this communication process.
There are two types of communication, which are verbal and nonverbal. Verbal is anything that you're going to say or you're going to write to somebody. Your nonverbal involves your body language, the way you hold yourself, your posture, the way you look. So that's why we discussed your clinical presentation when you're talking to someone. It also involves if you're touching someone or not. I think a big thing is, and we probably say this in our lectures, is does my face speak for me? So sometimes we may roll our eyes and not necessarily mean to, or we look mad, but we're actually happy on the inside, or vice versa. So this is looking at how we communicate, because in the hospital, sometimes we can get so busy, we don't realize that our face is speaking for us. So this is something that you might want to start working on, even just saying funny things to people, back and forth of let me say this sentence one way, let me say it another way, and see how it looks, because your verbal and your nonverbal can be very important when you're talking with your patient and giving them the attention that they need when you're communicating. We want those to match one another. So, if you're verbally saying something, then your facial expression shouldn't be something else. So they're supposed to be congruent in that to meet the goals of the patient. Your book does emphasize talking about communicating with a smile. And then when Ashley and I were discussing this, we're like, some things shouldn't involve a smile. Like if you're giving somebody bad news, that shouldn't involve a smile. But it does point out using smile, especially with elderly patients or with children. That's just kind of like a welcome that, oh, she's friendly or he's friendly, and they seem to be open to talking with me or communicating with me.
That can give you kind of two things about that, your appearance when you walk in. When you walk into a room, remember, if you're giving really bad news or even really good news, most of the time you're going to be doing that with the physician or with the nurse practitioner or somebody else. You don't want your facial expression when you walk in that room to give away what the physician's going to tell them. So even though you know you're going in to tell someone they've got cancer, that's terrible, but you don't want to walk in crying or with this horribly somber face, because the patient's immediately going to know, oh, there's a problem, and they're not going to listen anymore. So try to just be professional, kind of flat almost if you have to be, to avoid having that. But you don't want to give this false sense of everything's okay by walking in going, oh, I'm so glad to see you, when the truth is you're about to give them terrible news. So just practice, like Ms. Springer said, practice using those skills. Say the same sentence to a family member 3 times with a different facial expression and see how they interpret it, because there's a whole lot between, yeah, I'm doing fine versus, yeah, I'm fine. Completely different things. And as most of us who are either women and say those, or married to women who say this to you, you know, I'm fine versus I'm fine does not mean the same thing. So practice some of those skills.
Sometimes you know things before the patient does. So like a diagnosis, you've already looked it up, you saw the results of the CAT scan or the MRI, and you know, oh, their cancer's come back, but you're not allowed to give that information because the physician hasn't come by yet. So that's a good point to not already be upset and avoiding the patient. You know, you can pick up on that. We can pick up on that. Why are they avoiding us? Something must be wrong. And we start jumping to conclusions.
We used to say things like the poker face, and now I say, oh, that's my nurse face, because I can hide anything, or I can make anything feel like it's okay until it comes down to time to tell the truth. And that doesn't mean don't sit down and cry with your patient.
Right.
I have had to go in with a physician and tell a woman that her baby didn't have a heartbeat. We've both done that on more than one occasion. And it's perfectly okay, after that information has been relayed, to sit down, hug your patient, cry with your patient, whatever you need to do. But don't give it away before the information's been given, because now you've got the patient so upset they're not hearing what's going on, and they've lost track of the communication portion, and they're on to that emotional feeling portion. So just try to stay on topic with that. So some factors that affect communication. Personal space. Some of us are okay with personal space. Some of us prefer to keep inside of our little bubble. So trying to identify that boundary with people. You know, you all have met that person who's like, oh, I'm a hugger, and as soon as they meet you, they want to hug you. And for some of you, that's perfect, and some of you, you're thinking, oh, please don't. So try to have an awareness and watch how a person responds to you, so that you can make sure you're using appropriate interactions. So that being said, proxemics is a way to kind of identify what's appropriate based on the relationship you have with that person. So an intimate relationship is defined as interacting with someone from physical contact up to 18 inches. So right now, Stephanie and I are just a little bit over 18 inches. We're not sitting here touching the whole time, but we are in casual interaction, which is 18 inches to 4 feet.
I'm starting an IV on this Furr, and I'm going to be probably
more in that intimate space.
Yeah.
But before you enter that space, she said, I'm going to be doing this. This is how this is going to be. Are you okay with that? Are you prepared for that? Give your patient time to respond, and know that, yes, they're comfortable with me entering their personal space or not. So casual, 18 inches to 4 feet. This is what we're going to have most of the time when we're in a patient's room, providing care, doing things. We're kind of in their space. We're letting them know we're here and what's going on, but we're also not this close to their face when we're talking to them and making them uncomfortable. Social space is considered to be 4 feet to 12 feet. So if you're just casually having a conversation, You don't need to make this very one-to-one. If you're talking in a group setting to 3 or 4 people, 4 feet to 12 feet is appropriate. And then public space is 12 feet or more. So some things that are really important about your body position. If you walk into a room and you're going to talk to a patient, especially a patient that you haven't really established a relationship with and you're trying to get information, this is going to be ideal. If I walk into the room to get information from Ms. Springer and I stand up and look down on her, or stand at the door and say, hey, then you've established this superiority complex. You've made the patient feel kind of like they're under you. The other thing is, arms crossed. If you have your arms crossed, that's immediately saying, I'm closed. I'm closed for business. I don't want to talk to you. I don't want to hear from you. Open body posture. Thank the person that you're talking to. Make sure that you're working with them so that they feel comfortable relaying information. Not sitting there twisted away from them saying, yeah, I hear you, while you're typing on your computer, because that's not providing them that attention that they need, and your body position can really impact that.
When we look at language, steer away from the medical jargon. Sometimes we get caught up in that and not bringing it down to that health literacy level that they are used to, finding out, what do they understand? So if I say you have this diagnosis, what do they know about that? So making sure that you're not speaking out of turn. If somebody speaks another language than you, then, if you're asking somebody and there's a family member there and they're saying they need to go to the bathroom and the family member says, oh, she's saying she needs to go to the bathroom, that's fine. But if you're looking to get consent or even the physician comes in and he wants to talk to the patient about how she's progressing in her treatment, you cannot use a visitor or a family member. It has to be somebody that's approved within the hospital, or the computers now can talk, right? That you use those because that could be a breach of confidentiality. We don't know exactly what they're saying because we don't know that language.
Make sure you write down the name and number of the person that you utilize. Because so if you use that interpreter line or you use an interpreter in the facility to cover yourself, you need to document the name and the number that you use, because otherwise the patient can come back and say, I had no idea that's what they meant. Nobody explained it where I could understand. So that takes the legality off of you, because you said, I use this interpreter, this is what I said, this is what I explained. They didn't necessarily understand it, or the interpreter said, yes, they verbalized understanding, those kind of things. But make sure that you have that documented, otherwise you put yourself at a place of liability.
Everybody has bad days, but I have seen nurses before run in and out of patients' rooms talking about how busy they are. And my first thought from a patient is, if they're busy, then they can't help me. And a lot of patients don't like to ask for help. They have issues with that, or they don't want to be a burden. Well, I didn't call out because I didn't want to bother you. I know you're busy. So make sure you portray a positive attitude. If you hate where you're working, who you're working with, suck that up when you're in a patient's room and try to portray a positive attitude. So don't try to be negative. Don't try to bring in what you've got going on with yourself, what kind of day you're having. Somebody's at home sick and you can't get to them, those kinds of things, because you want to make the patient know that they are your priority. When you're in their room, they're your first and only priority at that time.
When you get ready to leave their room, the best thing that you can do is say to them, is there anything I can do for you right now? I have the time.
Yeah.
You may not. You probably don't have the time.
Right.
But to make that patient feel like this is their moment, I have the time. Because if you say that and they really needed to go to the bathroom, but they didn't want to ask because they didn't want to bother you, they'll say, well, while you're in here, can I go? Yeah. If you don't say that, and as you're walking out the door, say, can I do anything for you? And they say, no. Then in 15 minutes, when you're in the next patient's room, guess what? Your phone's going off. Hey, the last room you were in needs to go to the bathroom, because you didn't give them that opportunity. So make sure you end with that statement. Can I help you? I have the time. And that's really going to help your patients feel like they're a priority for you. Emotion. So emotion. We talked about this briefly a moment ago. When you enter a room, you can have feelings about a situation. Maybe you're going in to care for a patient who has COPD and your grandmother died of COPD.
Yeah.
You obviously are going to have emotion with that patient. But if you go in there with these kind of negative feelings because you know what happened in your family with that, you can give some uncomfortable things for the patient. And so we want to avoid that, and we don't want to use terms or anything that can be misconstrued. So, for example, we want to focus on the goal. We want to be careful about our word choice. We could say something very simple like, John has plantar fasciitis. And as a family member, you're thinking, okay, he's got a foot problem, but what is it? And we can tell you really simple, that just means that this tendon and this ligament is a little overworked, and we're going to stretch it out and he's going to be fine. And your patient's going to feel great. If you come in and say, I need you to know your loved one has a foot disease. Okay, now we're thinking, my loved one. We're going with loved one instead of the person's name. So now you've got this emotion of, it's somebody I care about so much. And you didn't just say simply they have this problem and this is what it is. You've gone into describing a disease. And to people, disease can mean 1,000 different things. So those connotative meanings that go with words can really impact people. And it's different for everyone. So try to use very straightforward and focused terms when you're discussing important medical care with patients, so as not to get them emotionally involved. Because once they start thinking about death or love or cancer or any of these big Q words, they're not really worried about what you're saying anymore. They're on the emotional aspect of that feeling or that patient or that person that you're talking
about. Active listening, that is when you take in all the things that are coming from your patient, whether that be what they're saying, how they're acting, are they fidgeting, what kinds of things are they doing to help you interpret what they're saying and the messages that they're giving you. So it helps you to understand where they're coming from, what's their greatest concern. And it's hard sometimes to actively listen because we want to interject, or we've got too much going on and we need to get out of the room. Some people talk a little slower than others. Some people talk faster. Some people don't say what they want to say. They do it in other ways, so maybe in other behaviors. So sometimes just listen and saying, making sure you're hearing what they're actually trying to tell you. So you can restate things. If Miss Furr says, this place stinks, then I could say to her, well, what's going on with you? Why do you think this place stinks?
Because I haven't had anything to eat at a consistent time in 4 days.
So you haven't had anything to eat in 4 days?
No, I've eaten, but it's just not when I think I need to eat. I don't eat dinner at 4:30. I eat dinner at like 7 o'clock.
So you're telling me that our meal times are not what you're used to at
home? Yes. Okay. So that's a perfect way to restate, because if she hadn't really thoroughly listened and didn't restate that, she could have walked out of the room going, she hadn't eaten in 4 days. She's making that up.
Yeah, she's up here saying she hadn't eaten. I'm not worried about her. We know she's getting food. I saw food go in her room.
Exactly.
I'm done with her.
But then when you follow up and hear somebody say, I get lunch at 12:30 and then dinner at 4:30, I'm not hungry and then I'm starving by midnight.
And it is different.
It can be a way to say, well, you know what, maybe we can make arrangements to get your meal tray delivered last or something like that, so that they're maybe eating at 5:30 or 6 o'clock. So that's a great example of how making sure what you're listening to is actually what they're saying to you, because sometimes patients say things in their head that make sense and it comes out a whole different way. So some styles of communication. You have passive or avoidant, aggressive, and assertive. So a passive or avoidant style of communication is someone who tries to just avoid confrontation altogether. They don't really want to talk about how they feel. They don't want to express themselves. They're not likely to ask for help. They're just kind of like, you know what, it is what it is. It's fine. I'll survive it. Not necessarily going to get the help they need because they're not going to ask for it. And even when you ask them, they're not super excited about telling you that. So those people, you really need to give them opportunities to express themselves. So they can trust you. Absolutely.
Then we have the aggressive communication style, and these are the people that are all about me and what I need, and nobody's taking care of me, and where is this, where is that. They come off as extremely rude, and they can be the patients that a lot of people want to avoid, or say, it's somebody else's turn, I can't deal with this. And so we have to kind of step back and say, okay, let's think about their full situation, what they have going on for them is stressful. This is what's most important, and let's see how we can calm them and get to the root of what is causing their anger. Why are they acting out in this way?
A lot of times, if you can figure out why they're so angry, then you can change that relationship and make them
And they'll be as
communicate
nice
with
as they
you
can be.
in a whole new way, and then everybody's day improves. So that's a great point that Ms. Springer made, is trying to figure out why, not just acknowledge they're rude or they're aggressive with the way they talk to me, but figure out why they are that way and then try to help fix it. And lastly, we have an assertive personality, and this is the most effective method of communication. This is somebody who's coming in and saying to you, like, I don't want to hurt your feelings, I don't want to make you upset, but this is what we need to do. And even though you can, this isn't all about me, it's about the topic at hand. So I understand that you may be overwhelmed with all this new course material that we're giving you, but we need to do this at this pace to make sure that you guys get all the material you need for the NCLEX. And even though it can feel a little bit intimidating or a little bit overwhelming or daunting at the beginning, their purpose of that communication is to state facts, give out pertinent information, and a reason to go with it so that you understand this is what we're doing and this is why. It's not necessarily to benefit me, but to make the whole picture work correctly. And so that is the most effective form of communication, and something you should try to practice using is stating facts, giving out pertinent details, but not necessarily making someone feel bullied or intimidated in the process.
Okay, so when we're looking at therapeutic communication techniques, these are some of the things that you'll want to practice at home before you come to your sims, because these are the types of things we're going to be looking for during your simulation. Did you participate? You're going to look at it from your perspective and tell us how you met these goals and use this type of communication, as well as we're going to be looking from our end to see how you met that. So there's a box on page 106, box 6.2, that talks about these forms. So providing general leads, using silence, offering yourself, open-ended questions, validating, restating, seeking clarification, giving information, reflecting, looking at alternatives, and then summarizing. So Ashley and I are just going to do a couple of quick scenarios, and then we'll tell you which ones they fit into, so you can kind of get some ideas of what these are actually mean when we say use this style.
I'm a patient.
Sure. You want to be a patient?
Sure.
Okay.
I'm really tired. I don't want to be here anymore.
So you're saying that you're tired and you don't want to be here anymore?
Yeah, I'm done with this.
Well, tell me more about that.
I miss my dogs. I miss my kid. I don't want to be in the hospital anymore. I feel like people come in and just poke at me and prod at me all day, and I still don't know what's going on.
Okay, so have you thought about why you're here and some of the reasons that you're here?
Well, yeah, I thought about them, but nobody's answered me.
So what kinds of questions do you have that we haven't answered? Can you tell me some of those?
Sure. So some of the things that we kind of went through there were open-ended questions. Tell me more about that. That gave me an opportunity to expand on kind of what I was feeling, and then seeking clarification and restatement. Ms. Springer did a great job of using both of those by saying, is this what you mean? Well, yeah, but this is why. Seeking clarification, asking to explain, so why do you feel like you need to go home? What's missing that makes you feel like this is not an ideal situation? And so by doing some of those things, it gives me choices. And then she also used this lovely looking at alternatives theory by saying, why are you here? And reflection as well. think about what's going on. Why are you here? Nobody's in the hospital that doesn't really need to be. And so trying to put that back on that person to give them an opportunity. I know you don't want to be here. I know you want to be home with your dog, but why are you here? Well, because I couldn't breathe. Well, then we really need to get that fixed all the way before we discharge you. Otherwise, you might end up right back in this spot in 2 weeks. So, even in just that 2-minute exchange or less, we cover more than 50% of these. And sometimes using silence can be a little bit uncomfortable the first couple of times you do it. But because it's uncomfortable, people want to feel the silence. And so if someone tells you, I'm just really sad, and you sit there and don't say anything for a moment, they're either going to say, I'm upset because, and if they don't start talking, you use the silence for 10 seconds. They didn't respond, and you can say, I'm sorry that you're sad. Talk to me more about that. And that right there is 2 different opportunities: open-ended questions, general lead, and really using silence. So there's a lot of options there. Practice these and get familiar with them so you're prepared for Wednesday.
On the flip side of that, barriers that we see. So we were going to do a couple of questions here. You can read the list for yourself. We'll hit a couple of those just to give you some examples as well on this end.
So a good example is, are you hungry?
No.
What do you want to eat?
Nothing.
So when you give someone a very short yes or no, nothing, this or that answer, you can't really find out why they don't want to eat. For example, you could give them a more open-ended question or phrase it in a way that gives them an opportunity to say what's going on. Well, if you're saying to me you don't really want to eat, can you tell me why?
Well, I don't like it.
There you go. What can we do to make the food taste better, and plan for that, versus do you want to eat now? No.
Yeah.
Well, I don't know why, and if I had known that it was because she didn't like the food, we could have made a special dietary modification. What if this patient's in the hospital for dehydration and malnourishment? Obviously, we can't skip meals just because it doesn't taste right. We need to find an alternative. So other things, we don't have any money. I don't know how I'm going to pay for this new medicine. I mean, my husband's new diagnosis. I just don't know what I'm going to do.
The money always comes. Don't worry.
It comes for you.
Don't worry about it.
Don't give someone false assurance. Don't tell them everything's going to be fine. You are not in control of that. You can go with, I'm sorry you're going through this, and we will do everything we can to help you. Give that positive, but don't tell them it's going to be okay, because it may not. But I will do everything I can to help you through this is a perfectly acceptable statement. So continue to look through some of those things. We don't want to belittle a patient. I don't know how I'm going to afford to pay for these medicines.
Why are you worried about that? It's not a big deal. Girl, you are here because you are sick. That don't matter.
And a lot of people take that theory.
Mm-hmm.
You're here because you're sick. We'll deal with that when we get out here. A much more appropriate response is, I'm sorry you're worried about that. Let me get you in touch with case management who can help you find an affordable medication.
A lot of readmissions are because
they didn't get their medicine, and they never told you they didn't, because nobody wants to say, I can't afford it. And then you just
shut the door by saying, why are you worried about that?
Yes.
Like, that doesn't even, and then they're not going to talk about anything else with you because they're done.
So let's take an opportunity, look through those, practice those open, positive therapeutic communication techniques, and then see how asking questions in other ways can be barriers, and make sure that you're prepared to try and avoid using some of these barriers in SIM on Wednesday.
So this is in your book on page 107, talking about how to communicate during a crisis. I think a lot of this is because when a crisis takes place, everybody gets anxious, uptight, and stressful, and they forget to put the important pieces in there. Or you're new at this, and so, it's your first time calling, and I can remember nurse saying, please come for me. I don't know how to do this, or I don't like this doctor. He likes you, doesn't like me. Those kinds of things. Or nobody wants to tell a doctor that you gave a patient the wrong medicine, or you did something that you shouldn't have done, or you didn't follow his orders correctly. So this is just a way in which to communicate that, making sure that you have everything that you need before you call, so that you don't get hung up on maybe because you didn't have what you needed.
Hopefully you have nice doctors who won't do that to you. But based on some of our experiences, they might. So when you call, we're worried about the fact that this patient has a low blood sugar. So I'm going to give a quick example of a phone call, and I want you to listen to Dr. Springer's response and then think about how you would feel if you were the person on the other end of the phone call. So I'm calling about Mr. Jones in 304. His blood sugar is like 47. He's cold. He's not really responding well. We need something to give him.
Well, when was his blood sugar? Now or?
Like, I think it was like 15 minutes ago. I can get my papers and look.
Okay. Has he had any insulin?
Let me pull up his MAR real quick.
You don't know if he's had any insulin today, what has caused his blood sugar, has he eaten today, is he scheduled for surgery?
Let me call you right back.
You might need to do that.
That's a pretty accurate exchange, not very pleasant. So let's try again in a little bit more informative way. I've looked up my information, so let's try this. Dr. Jones, this is Ashley. I'm calling about Mr. Smith in room 303. He was admitted for small bowel obstruction. He's been NPO for the last 48 hours. He was observed to be cool and clammy at 1915. At 1920, I took a blood sugar. It was 47. He's been given 10 mLs of D5 per protocol. His blood sugar is only up to 52. How would you like us to proceed to get his blood sugar back up?
Thank you. I think we call this patient. And since he has NPO, let's go ahead and continue and give another dose of another amp of D50, and then recheck the blood sugar in 15 minutes and call me back with those results.
Okay, so you want 1 amp of D50 and then a recheck of the blood sugar and call you back with the results in 15 minutes?
That's
okay. So go through that process. If you write this down in your head, this is for introduction, who you are, what's the purpose of your call. Give the situation. The patient's here. He's been NPO for 24 hours, and that's why he's going through this. I assessed him, and I see that his blood sugar's low, and he has symptoms that match. He's cold and clammy. I think that we've already done this. Can we try X, Y, and Z? That's the recommendation. And then if they approve your recommendation or give you one of their own orders, then you need to verify that that's correct. So go through this process, practice this process. Anytime you're even getting a report from another nurse, you can practice this process so that when you do have to make those first few phone calls to the physician and get yelled at, that you will be appropriately prepared.
Because a big thing is when they give you an order, because 9 times out of 10 when you call and you give information, then they're going to give you an order back. Once you hang up, you can't look at the nurse and say, I didn't get the milligrams. I think he said 12.5, or did he say 1.25, or what did he say? Well, we don't know, and we cannot go off speculation. So that's going to be another callback. So, hey, hold on just a minute. Can you repeat that one more time? And let me repeat it back to you just to be sure. That might be a little bit aggravating, but that's way easier than having to pick the phone back up and say, I didn't hear you. I'm calling you back again. I've done that before. That's why I say that here.
When you call, have a piece of scratch paper and a pen in front of you, because you may think you're going to remember it.
You will forget it.
You'll probably forget it, especially if somebody comes up and starts yelling at you. Hey, tell them such and such why you got them on the phone, because they don't want to call. So like you're talking about your patient, somebody else comes up and starts yelling at you to tell them so and so. You'll forget what he told you. So just grab a piece of pen, a piece of scratch paper, and a pen, and go ahead and just jot down what he's saying. And then when you go to read back those orders to your physician, he or she can then say, yes, that's correct. And if you've made an error, then you know exactly what it is. So when you go to do that, fortunately, we have CPOE or computerized physician order entry. And so most of the time, the physicians are going to enter their own orders, not always. But if they're not available to do that and you're writing that down, you'll have that accurate information so that you'll have it when you go to enter it. So box 6.3?
Yes, attempts at resolving conflict, which will happen when you are looking to, I guess we'll look at PowerPoint first, when we're looking at upward communication examples. So that's speaking to or interacting with someone that is authoritative or above you. That could be your nurse manager, that could be the RN, that could be
Position,
Position,
charge nurse,
yes.
house
Yeah.
supervisor, pretty much
And kind of the
anybody.
things we were talking about, taking an order over the phone or something written. The box does point out when you're speaking to someone that you've had conflict with that you go directly to that person, because if you go to your manager, the first thing she's going to ask is,
Did you talk to them yet?
yeah. So this just gives some key points to look at. We'll let you look over and read those. It's talking about expressing your feelings, but not being, not accusing them. So instead of saying, you did this, you did this, you did this, you would want to say, well, I was involved in, or this situation where we, so you're not just like accusing the other person.
I felt upset when this occurred.
I apologize on my end if you misunderstood me, whatever, in that way.
And make sure you talk to them before you seek out assistance. That doesn't mean don't go to your manager or your supervisor or your charge nurse, whoever. Do those things as appropriate. But if I've gone and said, hey, I've noticed that you haven't been able to chart your I's and O's all shift.
Yeah.
Can you please get those in for me so I can update the physician? And then an hour passes and I still don't have them. It may be time to step it up to the next level, because I've already done this. Yeah. I've already reached out and communicated. It didn't work. Now go up to the chain of command. So not to say you don't need to use that communication with those in an upward style, but try to be communicating with your peers equally first, to give each other an opportunity, because I always would prefer somebody come to me first and say, hey, I noticed problem A, B, or C, and give me an opportunity to fix it. Because anytime I hear it coming from my boss or my manager, I feel a little like, oh, I'm in trouble. Where if one of my friends says it to me or one of my peers, I'm like, oh, let me fix that real quick beforehand. And it almost can feel like they've helped you out versus disciplinary action if it's coming the other way. So not to say don't climb the ladder as appropriate, but reach out first. Yeah, that's true.
That kind of thing. I mean, like you don't have to.
You have to do
or
it.
the things that we'll talk about that you have to automatically repeat.
Absolutely.
Yeah. What's next?
6.4 on page 108.
Okay. So that is looking at talking to your supervisor and how to go about that, making sure that they're informed of situations so that they're not blindsided by somebody else, that a situation has evolved. Making an appointment. Be careful that you're not blaming or exaggerating or using dramatical expressions. Make sure you've calmed down so that you're not just irate and not making sense. That's the same thing I think with written. Like when you send an email, they always say if you're upset and you've typed the email up, don't send it then. Give yourself some time to calm down, come back, look at the email, clean it up, and then if you think that it's still necessary to send, then send it. If there is an issue, maybe you can start discussing new ideas of ways to fix it. Maybe it's just not a one-time deal with this person or this situation. And then making sure that whatever they tell you, the feedback that they give you is acceptable, you acknowledge it, and you understand it. So you can't go back and say, well, I thought you said to go and do this or tell her this. Just make sure that the lines of communication stay open across that.
Anytime you go to your supervisor, your charge nurse, your manager, your physician that you're working with, anybody that you're working with, if you go to them with a concern, but you also have a fix for it at the same time, it's going to work out much better. Just like on the previous slide, when we were looking at that ISBAR portion of the recommendation. When you call the physician, like here we've got the orders that they're taking over the phone, if something doesn't coincide with the plan of care that is established for the patient, make that recommendation. That's perfectly acceptable. And then just read that back and verify that you've got that. That recommendation is always going to help, because you've gone from I'm whining, complaining, and tattletaling to I've identified a problem. I've got an answer. How do you feel about this? And those are two different scenarios, and you're going to get you're going to have a lot better reception with your physicians, with your staff members, if you say, here's a problem and here's a fix for it. How do you feel about that? And then accept that feedback they give you about how to change it. Then if you just come up to somebody and say, I am so tired of dealing with Joe. He does not do his job.
Hey, I'm just going to not talk to him no more. When he's assigned to me, I'm going to do all his part. That won't work, because then you're overloading yourself with what should be his job. So that's not it.
versus I
Yeah.
talked to Joe twice this week about making sure that blood sugars are documented on time. Do you think maybe we could have a overall unit orientation or refresher about the importance of glucose timing before meals? And that way, I'm getting the message out to everyone, and it would be good for everybody to learn. And your manager is going to be much more accepting of, hey, she at least gave me an idea than he came to me and fussed for no reason. So try some of those techniques, and always whenever you are using written or over the phone communication with your provider, make sure like Ms. Springer said, that you've reread it and it's appropriate before you hit submit or put it in the patient's permanent record. And then if you're taking an order over the phone, that you have reread that back to them and verified everything is correct before you put that in the patient's permanent record as well.
Downward communication is anyone that you give instructions to below you. So for you guys, that would be like your UAPs or your CNAs. So this is kind of also looking at delegation, I would say, making sure that they know what to do and how to do it, that their job rationale does fit it, is within their scope, that they've been allowed to practice it. You know the policy and procedures, they know the policy and procedures, that you have given feedback, whether it's positive or negative, which can be difficult to do sometimes, and making sure that it's readdressed, that they could come from another facility and that's how they did it at that field facility and nobody has showed them the policy and procedure here. That can happen a lot when you're switching between jobs and facilities. And then making sure that you've role modeled it and said, oh, okay, well, let me show you how we do it. That way they've had exact instructions on how to perform it, and then you can go back and evaluate them and make sure they are performing appropriately.
All things to do before you initiate that chain of command of saying, so-and-so didn't do their job first.
Mm-hmm.
Give them an opportunity, provide feedback, show them an example of the policies and procedures for the facility, show them how to do it yourself, and then if you continue to have problems, then start that chain of command. So communication with the healthcare team during shift report. Number one, this is confidential. We all see nurses sit at the desk, they take a report on a piece of paper. Now the facilities, most of them have gone to an online shift report that they really prefer that you use exclusively. And it's under a report tab. That's something that we'll be able to visualize more when we get into the clinical setting and can discuss further in detail then. But in the meantime, know that that should include very specific pieces of information. Who the patient is, what room they're in, what are they there for. If they have any safety concerns like a fall risk or droplet precautions or isolation precautions. Sensory deficits. Mr. Smith is a stroke and he can't feel on his left side. Well, obviously you don't want to put his phone and his stuff on his left side because now he won't be able to grab that to call you for help. Scheduled procedures. The last thing you want to be is the nurse who has the patient who was scheduled for a CT scan at 10 o'clock and had to have a special IV in a special place, and you didn't write down a report it was due, and at 10:02 they're calling you saying, where's the patient, and you haven't even gotten them ready. Write those things down at the beginning of shift so that you can plan your day. Pertinent diagnostic results. I don't know about you, but I personally do not have the time to write down 75 labs on 10 different patients that I'm caring for that day. If they're here for cardiac problems, I'm probably going to write down my cardiac labs. If they are here for liver problems, I'm probably going to write down my liver labs. That's it. All that other stuff that's in the medical record that you can access at any time, you don't need to document elsewhere. That's an opportunity for a transcription error. That's an opportunity for HIPAA violation if the paper gets dropped, anything like that. Only what you absolutely need to have for the care right then. Assistive equipment. Does the patient use a walker or a wheelchair? Absolutely pertinent information in shift report. The last thing I need is during a report somebody to call out on the call bell and say they need to go to the bathroom. I haven't gotten a report and I walk in there and try to stand them up and they don't tell me they can't stand and they hit the floor. Find out what that patient uses. Do they use a walker every day? Then have the walker readily available. And that also applies to prosthetic devices. And we think of prosthetics as arms and legs, right? We forget that dentures, eyes, hearing aids. A hearing aid is a prosthetic device. So if someone uses hearing aid and dentures and you provide them with neither during their care for the day, now they didn't eat, they don't have a clue what's going on, they're yelling back at you because they can't hear you and they're frustrated and now you are too. So make sure that a person has everything they need. relay pertinent information and shift report. You don't have time to give their whole life history. Pick out those very important things and give those out. And that's something you can work on in clinical is carry a highlighter in your pocket, and when you feel like something is important, highlight that. And the first couple of weeks you're there, you're probably going to highlight 3/4 of your paper. That's okay. By the end of the semester, you'll only highlight those 10 things and your report will flow smoothly. So just start practicing that skill, highlighting what's important. And if you leave out something, then maybe have a second highlighter in your pocket of a different color to say, hey, this is what I missed. And so you'll remember it for next time.
So communicating with other members of the healthcare team, if you do this in writing, we kind of discussed that. Know who you're writing to. If you're sending out an email, say you have different responsibilities on your unit, you know the purpose of the email, who it's going to, why it's going to. Maybe you're communicating with physical therapy and they said that they could walk an X amount of length and they were good. And then you got them up to go to the bathroom and they did horribly and you wanted to let physical therapy know that. Something like that. It goes by the acronym of KISS, which is keep it short and simple. So you don't want to put a lot of detail into it. You just say, when I got this patient up, they had this amount of trouble, whatever, whoever you're talking to. I think something else we were looking at is care plan. So you'll be involved in assisting the RN with the care plan. So making sure if you're writing up an incident report, anything like that, that you're keeping it simple. Why did it happen? Why did that mistake happen? What caused it to happen? And we'll show you guys that when we get to Atrium, how they report their incident reports. Hopefully we won't do any, but we'll have it there so you can see it. Making sure that you're writing in proper grammar. So now everybody sends everything in text, and they have their own LOL, that means laugh out loud and all that kind of thing, would not be appropriate to include in your written communication unless it's an approved abbreviation for the facility or in medical terms. So just be mindful of that when you're communicating, that it actually makes sense. I think you used an example when we were looking at this.
Yeah, using make sure you're using like what happened, not what you think happened or what you felt like. If you're writing in a report for an incident, you're not going to write, I heard Miss Jones fall out of bed.
Right.
You didn't hear her fall out of bed. You heard a crash and you found Miss Jones laying on the floor.
Right.
Those are very different things. And by stating, I heard a crash, I ran to room 312, I found Miss Jones on the floor. Those are statements of fact and not open for interpretation. If you say, I heard her fall on the floor or I heard her fall out of bed, then you've kind of set yourself up, because first off, that made you say that you knew she was in the bed and you really didn't because you weren't standing there looking at her. So that could kind of hem you up legally. So make sure that you're not thinking about what you thought or what you felt, but you're just simply stating, I heard a crash, I found her on the floor next to the bed, she complained of 4 out of 5 pain on her leg or something like that. Just very, very matter of fact statements, especially for something like an incident report, because the goal of that is to figure out why this happened and how to fix it. And if you start saying things like, well, I feel like this was why. I feel like she fell because there was a cord in the floor. No, that's not your job. Your job is to say, upon entering the room, SCD power cord was entangled in her feet. Then somebody else can say, this is a likely cause, how do we fix this? Run the cord under the bed from now on, something like that. But an incident report or written communication should be statements of facts, brief and concise, short and simple.
Okay, so when we're looking at patient-centered communication, so your patient is your main focus. You want to encourage and empower them to participate in their care. So we'll talk about that tomorrow, actually, when we're looking at the nursing process and realizing that the best way to get patients to participate in their care is for them to help set their goals. So we all know that if we involve them in their care, then they're more likely to be successful, to heal, and to do like they're supposed to when they get home. We want to be attentive to their needs, whether that is the patient that is rude and obnoxious or the sweet little lady that never asks for anything. So we want to make sure that we treat everybody the same. Everybody has the same rights. We shouldn't avoid patients just because they talk too much and we can't get out of the room, or because they're mean to us every time we come in there. We want to be attentive and address them, because nurses spend the majority of the time with their patients, so they're more likely to pick up on changes in the patient's condition. If you're avoiding your patient, guess what? You won't be picking up on changes
happens.
in condition. Always use a friendly tone of voice. So sometimes we can get tired of going down the room and somebody asks for, oh, can she have a coat? Can she have a coat too? Can we get another blanket? She's cold. And it's not even about the patient. We want to still use our friendly tone of voice when addressing that. We are not always providing for everybody, right?
You can remind them
But you can,
anything that you need. Please
right,
feel free to
please
come
feel
up
free.
to the nurses station and ask for those items.
Yeah.
And then when you need patient care, you know, you can come down and things like that. And then focus on the patient, not just the task. So it can be really hard, especially if you're taking care of a patient who's maybe confused or nonverbal or maybe sedated, to go in and just like, oh, I'm here to do Foley here, and just do it and hurry through it and get out. But then the patient begins to feel more like an object than a patient. And so going in and saying, hey, this is what's going on today. We're going to do some Foley care, and just trying to talk to the patient a little bit while you're doing that. I'm sorry, I know this is a little bit uncomfortable, but while we get cleaned up here, tell me about your kids or tell me about your pets. Just try to make sure that you're focusing on the patient, not the chore, because if you're caring for the person, not the task, and you can change your mentality too. If you go from task oriented to patient oriented, you'll leave feeling better about your day too, because I helped somebody as opposed to I completed these 10 items. All right, so communication during a patient interview.
Sometimes you have to ask direct questions, like you need to do their admission paperwork and it has 59,000,000
questions that you don't really think matter.
Yeah, that you need to ask, which are your who, what, when, where, how, do, and is questions. And so once you've addressed those and kind of gotten those out of the way, those are the direct, maybe the yes or no, how many kids do you have, why are you here, that kind of thing. Then you can move into your non-directive questions, which are the ones we discussed before with our therapeutic communication, looking at open-ended questions and then exploring their thoughts and feelings, because we all know your mind can also play a factor in how well you heal and how involved you can be in your own care, you know, where you are with your thoughts and feelings in that. So that would be, you know, after you completed the interview, you've asked all those questions and not necessarily saying, well, then that's all I've got, you know, unless you need anything, I'm done.
Don't walk in there saying, here, I'm going to do your admission. I've got a whole bunch of questions. Just answer them real quick for me.
So we can get this over with.
Go in and tell them, hey, I know I'm going to be asking you a lot of questions. You've probably already answered a lot of these questions in the ER or in the ambulance, and I hate to do this, but I need to ask you again just to make sure we didn't miss anything. So feel free to interject. And all of a sudden, the dynamic has changed from, oh my God, I have to answer this all over again, to, oh, she's actually interested in what I'm saying.
Right.
Tell me what brought you in here.
And then
instead of what happened to you, tell me what brought you in here.
Yeah,
that
and then when she says something, you know, you can open up the door. Oh, my pet got in the way. Oh, what kind of dog do you have? You know, that
is Miss Springer's favorite skill set right there. It doesn't matter what's going on, and you will learn this in clinical. Your patient can have a major complication, and me and you will be down there dealing with that wound dressing, and we were working on all the details. And Miss Springer's up at the head of the bed talking to him. Tell me what's going on. And she's best friends with them by the time we get out of the room. But you and I have covered that wound, and we have every detail of it. So these are wonderful skills, and the more you practice them, the more you're going to learn to use them and integrate them. And I know that can be overwhelming when you're learning to try to ask questions, because you get distracted. If you're asking all these open-ended questions, you might miss those details. And so that's part of why Miss Springer and I go into the room with you and work on those. Is maybe next time she's going to do the patho with you on the Foley, and I'll be talking to the patient, and you'll get to see how you can interact and add those things into your practice as you develop more comfort with that skill.
Last but not least, talking about special communication needs. So if your patients are deaf or hard of hearing, talking louder does not make them hear you. And lots of times turning up their hearing aid just puts a buzz in their ear, and they don't attend well to that either. So make sure your book goes through several bullet points, making sure you use short, simple sentences, appropriate lighting. Don't chew gum in clinical at all. The book says do not chew gum. So we don't want you chewing gum either.
Look at the patient when you're talking to them. Make sure that they can read your lips. A lot of people, you will think that they can hear until you start talking with your back to them, and then they have no idea what you've said. And you realize, oh, they were reading my lips the entire time. Make the environment quiet. Like Ms. Springer said, yelling at them isn't necessarily going to help them, especially if you're trying to yell over the fact that down the hall there's a code and so everybody's yelling. Close the door, make the room quiet, mute the television so that if they are hard of hearing but they can hear something, that they're not trying to drown out 5 other sounds. They can focus on exactly what you're saying only.
And people that have aphasia, there's different types. Your book goes into detail in the box on 6.7. With most of those people, though, you will just want to make sure that you give them time to speak, that they aren't, that you don't interrupt them in their thought processing, because it could be delayed and they don't say anything for quite a while. That's when you can use your silence instead of interjecting. So sometimes I like to interject and talk for people. So that can be hard for me sometimes. But make sure that you're giving them the time to express it, because it is aggravating and upsetting to them that they can't get out what they want to say. That can also go into looking at patients that can't speak, which I think is
another topic. But you'll have people that maybe are unable to say the right words. They'll have expressive aphasia, meaning that they know exactly in their head what they want to say, like the sky is blue, but when it comes out, it might be cow purple. And then they're angry because they hear cow purple and go, that's not what I said at all. And so then they're frustrated. So you have to give them opportunities to do that, or they may get frustrated and have to give you some kind of example like pointing or something like that. So give those opportunities. And then visual impairments. You have a patient who has extremely limited vision or maybe blind. Please don't walk into the room and tiptoe around, not say anything, and then go over there and touch them and scare them to death. When you knock, my name's Ashley, I'm going to be your nurse today. Is it okay if I come in? Wait for them to answer you. Right. Then when they do, stand where they are close and say, I'm going to reach out and touch your right arm to assess you. Don't just grab them. Let them know what you're doing before you do it. And that applies to the mechanically ventilated or the unresponsive patient as well. Maybe just because the patient can't see you, or maybe because they have something obstructing their vision or their voice, like mechanical ventilation, doesn't mean that they don't really have an awareness of what's going on. They just can't necessarily express themselves. So give them an opportunity to hear what you're saying and process it before you just do something.
And also don't assume what the nurse before you has said. So I've had a patient before, especially a trach patient, that they say, well, he doesn't communicate at all. His wife's number and daughter's number is on the wall if you need it. I'm just not going to take what they say. I go in the room and I start asking questions, and believe it or not, he can nod yes or no.
Yeah,
he can't write, maybe because he's had a stroke or something, he's paralyzed. I don't know the situation, but don't just assume. Go ahead and try that, and don't just ignore that. You know what? He can't hear me, he can't see me, whatever. Then I don't have to worry about that aspect. This is the room that I can come in and say what I need to about my other patients, or say, you don't have to explain anything. I've seen people come in like respiratory therapists, hook up treatment to their tray and walk out of the room, and then say, hey, my name is so and so, I'm here to give you your treatment. Just don't forget that just because I can't hear that I can't see, or just because I can't see doesn't mean I can't hear, or vice versa. It's just don't treat them any differently than you would any other patient. In fact, you want to make those changes to be sure that you're addressing them appropriately. Another key thing is when you're looking at someone that is going to not be able to speak, so they're going in, they're going to get a trach. Those are things that ahead of time that you would want to know to try to figure out how you're going to communicate.
Do you want to have a tablet and type it up? Some people are proficient typers. I don't know if anybody watches Big Bang Theory, but Raj can't necessarily talk to girls, so he goes on a date and texts the entire time, and they have this communication, and they're happy. The communication exchange is occurring, but instead of verbally, it's done through typing. And so sometimes the hospitals or facilities may have like iPads or some kind of tablet where they can just type, or a keyboard, type what they want to say. Some people just want a pen and paper. Some people don't want to communicate with you in anything other than sign language, and you have to set up a video interpreter. You know, a friend of mine, I have a very limited sign language vocabulary, but if he and I are trying to have a conversation, it's almost exclusively done through text. And then pointing and verbal communication that we have that's kind of body language. You know, if Daniel needs to say something to me and I don't get it in our initial thing, then he'll pick up his phone, and a lot of times we don't even actually send the messages because it's a waste. We just pass the phone back and forth and read. So, I mean, see how that person wants to communicate or what their family uses at home and things like that, and then try to make them most comfortable by using a similar product or similar style of communication. All right. So we rolled through a good bit of that. I know that there was a lot of information there. I hope that we didn't overwhelm you, but you got a lot of the things that you need to know. Practice those skills. You're going to have to display those skills in lab on Wednesday. You can watch this video and utilize it as many times as you need. If you have questions about this or the PowerPoint or lecture or anything we discussed, please make notes and write those down and then bring them with you to class on Wednesday, and we can discuss them as a group, because if you have that question, somebody else probably has the same question. So bring those with you. You got anything else? All right, so we will see you guys in the morning. Please watch the video, send it to your friend if they haven't acknowledged that this is happening. Make sure you're making friends, because you're going to need each other. If you need anything, please don't hesitate to email us, and we will see you in the morning.